Hi, my name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis. I'm the director of the cardiothoracic and stereotactic body radiation therapy services and director of clinical trials. Patients with non-small cell lung cancer have a high risk of developing brain metastases during their lifetime. And as a consequence, and based off of numerous trials that have been done over the years, we know that the risk of cognitive deterioration from progressive brain metastases is significant. And left untreated, these patients often will succumb to a neurologic death. And while we cannot say that any death is better than another death, it's pretty clear that most patients are quite frightened by the idea of developing progressive disease in the brain and losing their sense of self and losing their ability to control themselves. And so we place a high emphasis on controlling the brain disease in these patients. Historically, to treat with radiation to the brain was to say that you were treating with whole brain radiation. It was the only approach. Whole brain radiation treatment has the appeal of being simple and effective and easy to deliver. Whole brain radiation treatment is typically given over 10 to 15 radiation treatments, historically using a very simple approach of a field from the left and a field from the right, treating the entire brain and trying to block out things like the optics and the nasopharynx and oropharynx cavity and mouth and lips, such that you were just treating the brain alone. The acute side effects of that treatment are typically manageable and include fatigue and loss of hair. But the biggest issue we've noticed over the last 20 or so years has been the late effects of that treatment. So importantly, with some really well done research by RTOG and others, we have clearly defined that in patients who survive and live more than 6 to 12 months after whole brain radiation treatment, that more than a third or 40% in some series will develop neurocognitive deterioration. However, we need to be specific about what that is. The specific effect is on short-term memory and recall. With that knowledge in hand, it has become clear that there is a tremendous intersection between the mild cognitive impairment Alzheimer's literature and then now the radiation literature. Because increasingly we have an understanding of the importance of the hippocampus or the limbic system in the impact of that short-term memory and recall deficit in patients who've received standard whole brain radiation treatment. Because of that, investigators in particular in Wisconsin pioneered an approach where they would give whole brain radiation treatment and try and spare or reduce the dose to the bilateral hippocampi, which exist in the medial portion of the temporal lobes. This is an approach which is technically advanced, and while it's become increasingly easy to deliver using automated tools, it still does require more effort than standard whole brain radiation treatment, which can often be planned in an hour if needs be. This is a treatment which is delivered with IMRT and therefore takes often several days, if not longer, to plan and deliver. However, the early trials were really exciting. RTOG 0933 showed that compared to background baseline deficits that would expect in short-term memory and recall, use of hippocampal avoidance whole brain radiation significantly reduced the risk of that cognitive deterioration in that patient population, and therefore triggered two different trials, one of which is ongoing and one of which is not yet reported. NRG-CC001 was a randomized trial of patients with brain metastases receiving standard whole brain radiation versus hippocampal avoidance whole brain radiation. And it met its endpoint of reducing the risk of neurocognitive deterioration and short-term memory and recall. And now, for many places, hippocampal avoidance whole brain radiation is increasingly becoming a standard of care in those patients who get whole brain radiation instead of, say, stereotactic radiosurgery. One of the nuances of this treatment, however, is that if the brain metastases are within or very close to the hippocampus, then sparing the hippocampus would be necessarily tumor sparing as well. And so oftentimes we say that those patients are ineligible for treatment if they have disease within usually around 5 millimeters of the hippocampus. However, there is really no hard and fast rules. At the end of the day, you have to make a decision for a given patient. If that patient has a single small metastasis within 4 or 5 millimeters of, say, the right hippocampus and everything else looks good, I would still consider that patient for treatment. I would contour in the target lesion that we need to make sure that we don't spare, make sure that the planning system delivers the full dose to that tumor, and then just accept that I won't be able to spare the full lower doses to those hippocampus, but it still may be better than nothing. The bigger decision these days often becomes, however, in which patients need hippocampal avoidance whole brain and which should just be treated with an extensive course of radiosurgery. Radiosurgery has become increasingly easy to deliver. There are new tools and new platforms that allow us to deliver treatment to many more metastases than we could before. The historical precedent of limiting radiosurgery to 1 or 2 or 3 metastases has quickly changed over the last several years, and there are trials that are ongoing to demonstrate what would be better for a given patient: radiosurgery to 5 to 15 brain mets or hippocampal avoidance whole brain radiation, and those studies have not yet reported. So overall, it is possible to deliver hippocampal avoidance whole brain radiation even if there are metastases near the hippocampi, but in certain situations, one might consider delivering radiosurgery instead.